what questions should somebody be asked, by their addiction specialist if they're seeing one now or getting ready to see one?
You mean on their first initial visit when they go in to see one?
Yeah, I guess my first initial one, and then even as far as someone like me that's been going, what questions, would you say they should be
Yeah.
asking?
When you're going, it's a whole different set of questions that you want to consider. But on initial visit, and this is an insightful question you asked, and you left it open, so let me answer it in that way. One of the things you don't want in any healthcare setting, which is asking a lot in 2020 almost, is a mechanical sort of run of the mill assembly line interaction. You don't want that in healthcare at all. In addiction, you really don't want that. So, because there's so much that has to happen here to have a good, positive outcome. When you come in, I watch you, and I'm not policing you, but I watch you. Everything from the way you come in, how you're walking, what you're doing, how you interact with the staff, how they interact with you, and then your movements. And then from there, our engagement is going to do a few things. Number one, because you're an addiction physician and dealing with such a complex beast, I need to build a rapport with you. And what that means is within that therapeutic professional relationship, you need to trust me and I need to trust you. Because with the addict and the way their mind has come to develop to work, and it's not them, it's addiction, and I can actually show this on functional MRI and PET scan, is they're constantly on the lookout. They've been lied to, they've been cheated, they've been hustled, right? They've been traumatized. And they themselves may have dished some of this out. And by virtue of the disease of addiction, they've had to lie, cheat, and so forth to get what they need. So they're kind of geared towards that kind of interaction. Now they're coming into a physician's office, okay? And the physician for them is, here's another coat. White coat, badge coat, black robe, PO, whatever it is. And you need to break that ice. And it doesn't take just once, multiple times. And you need to build a trusting, non-judgmental rapport. So that's really, really number one for the doctor to be able to develop that. From there, from you, I can get the classic, what's called medical history and physical, right? If I really want to treat this the right way, I need to make sure that you understand, and I do this, and then again in 2019, it's difficult with the way the marketing in the world is. You, as my patient, are not there to come in there and tell me, this is what I want. I make that really clear, okay? I'm not a prescription monkey. You're here for me to evaluate you, and together, we will get to a place where I respect your autonomy and your humanity, and you respect my professionalism and knowledge. I will educate you, and we will come to terms about how to go about it. So I make sure that you understand I'm not here to give you your prescription. I want to know your name, your age, your sex, your medical history, your social history, a very extensive drug and substance abuse history, and I need to constantly make sure you're very comfortable with who I am and you're open and honest. I keep reminding him, I'm not here to judge you if you are thinking that you're wasting your money and my time. I'm an old man. Don't waste my time. Your money is precious. Don't waste your money. And once we do that, so those things are all important, Jack. Your age, your use history, your other diseases. Do I need any lab work for hepatitis C, which is a big deal? And then once that's done, then you decide, you educate the patient. You tell them, these are what these drugs are. This is what the medical literature shows that these drugs can do for you. This is what your perception is about these drugs. And this is right. This is wrong. I'm here to give you the information. I'm here to give you the outcome possibilities of what you need. And finally, one of the things I do not do, and they should really be aware of this, you do not come in, pay me, get a prescription of a drug for a month. You don't do that, okay?
I'm so glad you said that because I feel like that's where a lot of the bad perception comes from on addiction specialists. Is there's a lot of doctors who seem to have got into it more of the addiction being such a market now, in things. So I'm glad you hit on them points because everyone's recovery is going to be somewhat different. And that's one thing I try to tell people is, you know, I think everyone has this idea on Suboxone that it should be just a medicine used to get completely off, which I agree in some terms, but at the same time, when you have people with real pain issues or, they got addicted because they were trying to get treatment for a pain issue, well, they still have the pain issue even after the addiction, even if they do better and start to recover. So that's why I try to let people know. I mean, there's such a broad spectrum of people who get addicted, and their needs are going to be so much broader.
I'll add to that, and I'll give you when you come in, and because I have access to a lot of service resources because I run my own facilities and so forth, you come in, if you've been on Suboxone for 10 years and your things are going great in life and you've just moved changing doctors, after we get to know each other and we verify that, sure, I'll see you in 2 weeks, and after that I'll see you once a month. But when you come in and there's so many issues, you're going to get 2 to 3 days worth of prescriptions, and you're going to see me, and you're going to see me again, and we will get you stabilized, depend whatever resource I may need, and you will work up to once a month prescriptions. And then after that, all the other stuff, whether it's urine toxicology, and that's how people should look for that, and I hope that answers your questions. They should look for someone well engaged, non-judgmental, and somebody who completely understands what addiction is, substance abuse is. And yes, I am the number one advocate of medication assisted treatment, but I don't just, like I said, I'm not a prescription monkey, man. You come in, we will build a rapport, and we will engage on a therapeutic journey together, and I don't know how long it's going to take, and you shouldn't know either. We will do this as it comes.
And I think too many people jump into it thinking either they're going to be done within a year, or you know what I mean, they jump into it with a lot of preconceived notions.
Yeah.
You hit on something about hepatitis C. So my next question is, I know a lot of doctors, at least what doctors I've seen, really don't, they'll ask about it, but they'll kind of leave that up to you. Do you actually get people into treatment, and as far as that goes, or get them trying to go in the right direction as far as getting treatment?
Thank you for asking. It's one of the topics I'm passionate about. My position, this is a word that people throw around a little bit. I don't think too many people understand it. In the United States, it's not certainly in the common parlance or the vernacular of the professional or the addict. My approach is harm reduction, chronic disease management. Part of that is understanding the significant role hepatitis C plays in the epidemiology of the addict population cohort. That's critical to understand if you're treating the addicts. That being said, I will distill it into simple language. Every addict that walks in through my door, okay, I don't care if they say I've always smoked, because you don't know what's going up the nose, needs to be educated on hepatitis C and needs to initiate lab testing and treatment. And I won't go into the details of how that's done. It's really simple. I will just say this. In the same way that we got to a point where everybody needs to get tested for HIV with rapid testing in the emergency department, every addict needs a hepatitis C test. It's a rapid test now that's just came out, that's out there. And in my case, I do my own treatment. I've learned how to do that. I work with the guy that is really the guy that wrote the textbook on this. I was fortunate enough he's around. It's not my traditional background of academic medical training, but I'm starting to become very good at it. But every addiction specialist, everybody that works in this industry and is an advocate for the addict should be out there with posters. Check hepatitis C. Check hepatitis C. In fact, my Harm Reduction Institute, we're out there trying to get a grant right now where the homeless kids with the addicts and stuff, I'm trying to promote this thing, and it's going to come out very soon here, where we want the company to pay. I want everybody on the streets to come by and get tested for hepatitis C for free.
That's awesome because it's rampant. I mean, and I don't think people realize how rampant it is. You know, I'm trying to think how to word this. I guess what's your, I guess I'll touch on that on a later date. I wanted to ask about your treatment stuff as far as Hep C, but I'll catch you on that another time. But
Okay.
uh, yeah, that's great that you do that. Just because I see a lot of addiction specialists that I've heard of and stuff that don't seem as passionate about the Hep C, and I just believe it's something that definitely needs to be handled. Especially trying to move forward in recovery. I'm dealing with it myself somewhat to where I'm actually having to stop using CBDs and start using ibuprofen so I can get treatment for my Hep C because just the insurance issues. So I guess my next question, Dr. B, would be what questions do you ask your long-term patients when they come in, even if they're coming in with clean urines?
I personally, by the time they're long term, and again, this is a mechanized medical delivery system, and it's dehumanized. And what I mean by that, in terms of the question that you asked about urine, I do my urine, but I couldn't care less about it. Number one, there's a lot of you have to understand how to interpret those things, and I think a lot of practitioners don't. Number two, by the time you're my long-term patient, you walk in, you give the urine, but you walk right into the door and you're like, I used, right? So I know what you use and when you use. By then, they know what we're doing here. Harm reduction. I'm non-judgmental. I couldn't care less. I'm here to take care of you. You had not a relapse. You had an episode of use, and that's something we can get into another time. I don't use the word you had an episode of use, no different than someone with chronic heart failure had an acute exacerbation of their heart failure. Okay, thank you for coming in. You're actually awesome. You kick ass. You came in. Thank God. Do you remember 3 years ago or last year or 6 months ago, you'd go on a 3-month run and lose your wife, your house, your kids, everything else. We have made significant progress. Congratulations. In fact, I'll probably buy you lunch today. Let's move forward from that. Other than that, let's say a stable patient, they come in and I watch gradually over time for our conversation to change from, did you relapse? Any cravings, any withdrawals, any significant stressful issues in your life. That's what I want to know about. Number one cause of relapse is stress, whatever stress means for that individual. And this conversation over time should gradually change into, how's your wife, how's your husband, how's your kids, how's your jobs, what's new? And we should get to know each other, because when you walk in that door, whether it's your first time or your 100th time, I look. Is his head down? Is he dressed okay? Is he smiling? Is there a flat affect, as the psychiatrists call it? I'm not a psychiatrist. I look for all those things. I want to know if there is something in your life that indicates whether you have stress that might trigger use, or you've used. And I want to get to a point where our meetings is, hey, here's your refill. Say hi to the kids, and I'm happy your job's going well. Let's talk about the news today. And so that's how I do my questioning. It's really geared towards, initially, are you using? Eventually, is there any stress in your life? And finally, is everything stable, and do I need to worry about anything? Other than that, they do the urine, so I'm compliant. And every once in a while, there's somebody that I use my urine to check what they're doing. And every once in a while, I do walk in to check with these older patients. But that's my sort of algorithm as you develop over time with my patient. I want to have a good time with you when you come in.
Yeah, and I'm sure you do. You could probably start to, like you said, once they realize you're there to help. Like, I'm honest with, when I've relapsed, I've walked into my doctor, like you said, and told him, because I knew I wasn't going to be punished. He was going to, talk to me about why did I relapse? Once I knew it wasn't going to be punishment or judgment, it was a lot easier to be open and honest. I know my recovery is solid. The last 5 years, my life's completely different. I serve my community. But for people who's not really educated on, maintenance, drugs, and recovery, a lot of people assume it's just a trade off from one drug to another. So, my question for you, an addiction doctor, is maintenance treatment real recovery? I know I'm really recovering, so, but to educate others, I guess.
Sure, no problem. I'm so happy you asked that question. Uh, the question for me is sheer insanity, and the only place you'll see this kind of questioning is the United States. Any other nation that's progressive, that cares about human beings, that is educated and is not driven by dogma, by moral judgmental bias that's based on nonsense, wouldn't even ask that question. I'm not talking about you. I'm talking about the fact that this debate exists in the United States, okay? And unfortunately, a lot of it is driven by 12 steps. I'm not knocking 12 steps. I think that's not what I do. I think whatever works for you, great. But, the very idea of you're trading one addiction for another is insane for one simple reason, Jeff, and here's why. That's not the definition of addiction. Just because I need something to stay alive and I need to take this, that I'm not addicted to it, right? If I need to take my blood thinner medication or my asthma medication or my cancer medication, I'm not addicted to it. That's what I need to
Or
make.
even antidepressant.
Antidepressants, I know they're against mental health drugs. That's what I need to maintain my physical, mental, social, and spiritual health. And if you're going to tell, addiction, heroin, or whatever it is, I escalate the dose. It becomes all consuming. It causes me hepatitis C, hepatitis B, HIV, soft tissue infections, endocarditis, pulmonary edema, overdose, death, jail, prostitution, and homelessness. Okay, that's addiction. Let's say Suboxone and it's working great. No Hep B, no Hep C, no HIV, no soft tissue infections, no jail, no prostitution, no losing everything I have. My physical health's good. I'm getting my Hep C taken care of. I'm taking care of my diabetes. I have a job. I have an apartment. That's amazing. Go ahead and call it addiction if you want, but you're insane. And I feel very strongly about this. I'm sorry.
And I love your views on this because I did since 2012. I've been in recovery. The 12 steps I believe in are great. I was luckily where my home group is a group that they don't get into what they don't care as long as you're living a good life. They just want to support you. But basically, what I'm getting at is I had a relapse 2 years into my first 2 years into recovery, and I had a little bit more than 2 years sober. When I relapsed, I would have died if I hadn't got on maintenance medicine. And I realized I had been white knuckling it for 2 years just to stay sober, not to go back to prison, more than to work on my recovery. Once I was on maintenance medication, I actually was able to work on my recovery a little easier, and I wasn't white knuckling it, the whole way through. So I got more out of my recovery after I was on, the medicine because I was able to actually focus more into it.
I applaud you and I praise you, and I think anything less than that, I don't think you got a little bit more out of it. I think you got a lot more out of it to focus on recovery. And part of focusing on recovery is getting on with life so you can build the correct neural connections and have a life. And do not ever, anybody out there listening, if you're on medication assisted treatment, and by the way, by very strict, honest definition, medication assisted treatment is methadone and Suboxone, not Vivitrol, not anything else. And there's a reason for that. But if you're on these maintenance medications, okay, you are as sober as anybody. And if you really sit there and meditate on what's being said here, there's an insanity here to say you're not sober. This is not a game. I don't sit here and say, hey, I'm going to beat this cancer without any drugs. Okay, drop dead, right? This is a serious business, man. This is no joke. and we have to all fight to get this view change and get the view change from the professionals. This should be non-judgmental. And when you're one last thing, when you use the term relapse, even that I don't like, and I'll tell you why. If someone, there's a negative connotation to it, like screwed up. You didn't screw up at all, right? When someone with asthma has an asthma attack, we all say, "Oh man, he relapsed. I relapsed." That's nonsense. He had an acute exacerbation of disease. He had an episode of use. There's no guilt. And please always remember that.
Yeah, I'm so glad you say that because I still am used to saying relapse. And I heard you say that a few minutes ago, but I'm one to believe if you go out and use, I don't believe that you lost your 2 years before that if you get back on the wagon, now, if you stay out there, I believe that's, you could definitely work.
Now it's a relapse. Episode of use or multiple can lead to a relapse, and even that shouldn't be a negative connotation. So yes, episode of use.
Yeah, I mean, and the thing is, I always try to tell people is you didn't lose nothing if you get back up.
No.
And then that's what, if I could stress anything to anyone, is getting back up is and that's the main thing. If you do that, you didn't lose that time. Use it to learn why you did go out and use.
You just nailed it. And I'm going to tell you something you can take home and tell everybody. You know how you say you didn't lose that time? I'm going to even put it into a more empirical, graspable thought for you. Not only didn't you use it, here's what happened. By the way, Suboxone does this because it gives time to brain. Every sober day that you have, and if you use Suboxone, it makes it this happens a lot faster for a bunch of, science reasons. But every sober day you have was a day that you gain tools, and I can actually show this in your brain, how to live a sober life. So you, like you said, you literally lost nothing. You gained tools to be able to get back on your horse. Does that make sense?
Yeah. No, and I like I said, I realized, I looked deep after, like I said, after the last time I went out like that, I did learn a lot about myself, codependent, some codependence relationships I had, things like that I needed to work on myself about. So yeah, I definitely agree with you that you're not, this notion that you just blew all that hard work for, because how hard it is for an addict to stay sober in 1 year or 2 months, whatever. That's a goal for us, especially just starting out. So that's one thing I've noticed. It seems like some addicts in the 12-step programs are the most judgmental about things that they should be supporting, because like you said, it's about quality of life. To me, it's about quality of life, how your life's going and where you're going in life. And, me on maintenance, most people would never guess I'm someone who's on maintenance, or even, some people don't even are surprised to hear I struggle with addiction, so, but like I said, like you said, it's a lot of dogma, and I appreciate you sharing your views on this and letting people know that, people assume Suboxone's like a medicine that gets you high or something. And like you said, people on Suboxone that's taking it right is no more high than, you know what I mean? It's something you're used to. So I appreciate your time so much, Doctor.
That was awesome. I thank you so much for having me on here. That was a lot of fun. Stay in touch. I see you on my channel all the time when you come in and say hi. I appreciate you following us, and reach out to us for anything we can do.
I will, for sure.
We have our channel. It talks about all the treatment stuff, but if you need anything, reach out to us.